So I thought I'd just give a little bit of a background. It's not very technical. Maybe I'm not supposed to have slides, but Mark said he didn't mind if I put up a few slides. So seeing as you're in Cork and you're in this region, just to give you a background. So here is the blue is the new catchment area for the so-called south-southwestern hospital groups. And this is a new development from the HSE to try and give centralised care to very specialised cancers, amongst which this clearly is. So here's some census figures from a few years ago. I had difficulty getting the up-to-date ones. The bottom line is, in this region, it's at least 20% of the national population. So there's significant numbers of patients in this so-called south-southwestern hospital group. And again, as way of a backdrop, this is a slide from Susan O'Reilly, who was the former head of the National Cancer Control Programme. And this is based on very strong data. So you can see how all of us are living in the midst of really nothing short of an epidemic of malignancy. You can see roughly 30,000 cases of all types of invasive cancer in 2015, and this is very realistically going to double over the next 30 years. So the prevalence, not just the incidence, but the prevalence of cancer will rise, and clearly NETS is very intimate with that, because the numbers of NETS patients being diagnosed every year is small, but because a lot of patients, thank God, do very well, the prevalence is disproportionately higher. So there's many NETS patients in the country today, thankfully doing well. I believe about 2,000 at least. So again, just to highlight in our region, this is quite scary to me, but this is based on data from the National Cancer Registry, who the interim head is Harry Comer, who's a well-known personality in the media. So this is an organisation that's government funded, based in Kinsale, and it collates national figures on cancer. No reasons to why patients develop the cancer, but it gives us hotspots and incidence and prevalence. And you can see here in this region, significantly high incidence of cancer. Myself and Chris Dorr and other oncologists and surgeons have day-to-day experience of this. So the HSE have designated that CUH is the regional cancer centre for here. And in the context of NETS, where we work as a satellite to a national centre, the HSE is the centre for cancer in the region, and the Mercy Hospital, the Cork General Hospital, or Kerry General Hospital, the South Infirmary Hospital, all feed in to CUH as the designated cancer centre. And unlike any other region in the country, every single surgical specialty that exists in cancer is represented here, whether that be hepatobiliary with Chris Dorr's expertise, pancreatic also, whether it be upper GI cancers, lung cancers, bowel cancers, gynae, breast, you name it, all the surgical specialties are represented here. So I'm very privileged to work here. So why is all this relevant to NETS? Well, I'm sure many of you have read this document. If you haven't, you should. It's available in Harry Comer's institution, freely Googleable. Just put in National Cancer Registry neuroendocrine tumours, and you'll read all this information on the numbers of cases per year, newly diagnosed and prevalent, and the age profile and the outcomes. Doesn't do anything with treatment, and that's probably a topic for discussion with this group. But you can see here how the total number of cases and incidence rates for invasive NETs are rising over this time period. And you can also see how, with relevance to GI NETs, which is the most common, whether it be upper gastrointestinal tract or middle, small bowel or pancreas, the rates equally are rising. So this makes it very important to have meetings like this to discuss how to manage these relatively rare in terms of incidence cancers. And you can see here the numbers per year is quite small, but the prevalence many years out is very high, very high. And this is approaching about 2,000 now. So what about NETs in this region? Excuse all the acronyms, there's every letter of the alphabet here, but NETs in HSE South-Southwest. So the Mercy Hospital, where myself and Chris Dorr and others who I'll talk about work, is really the centre here for neuroendocrine tumours. We link in with all of these institutions. This is the South Infirmary, this is the CUH, and then we have Kerry General, UCC. We have a little bit of academic research going on with this. ICORG is the national clinical trials body that Dermot and others are involved in. So any new drugs that are available for your diseases, this is a conduit within which they can come into clinical practice through trials. And then obviously the Cancer Control Programme, which clearly I'm very involved in. So what happens in the Mercy? Well, we have an MDT, a multidisciplinary meeting once a week. Given that we don't see as many numbers as the National Centre in Vincent's, we impregnate this MDT as part of a hepatobiliary and pancreatic multidisciplinary team meeting, which myself and Chris Dorr and others are involved in. And who are those others? Well, there's 3 medical oncologists, I'm one of them, 2 main surgical oncologists, Chris Dorr and Adrian O'Sullivan, 1 radiation oncologist, radiologists who are critical in this disease, as you know. There's 1 or 2 interventional, 1 or 2 metabolic, i.e. Octria scans, PET scans, etc. So we've 4 in total who are very involved. We've 3 pathologists. Pathology is key, as Dermot has mentioned here many times, because these diseases are rare and it's critical you get the grade and the proliferative index, etc. right. Endocrinology, by my own admission, endocrinology oncology is weak in this part of the country. We're working at this. And again, I'm being very transparent saying this. Jonathan has spoken to me about this with his experience. We're working on this. And clinical nurse specialists, we have many clinical nurse specialists who aren't dedicated to NETs, but we've 2 in particular. As Chris Dorr said in his surgical practice, he has an interest. These 2 nurses have a big interest in neuroendocrine tumours, and they play a critical role in the MDT and in the administration of many of the treatments that you're on. So what happens day to day? Well, patients get educated on all the treatments day to day. I hope some of you, I see many patients here who I have the privilege of looking after. I hope that's your impression. In terms of the octreotide injections, which is probably the most common treatment that's given, it's either the general practitioner who gives it, or in our neuroendocrine tumour clinic, which is impregnated into other clinics. And I know many of my patients have experience with Peggy O'Keefe, who's one of our nurses here, who's really married to her job. She's unbelievably devoted. She gives many patients octreotide injections every week. We check, obviously, the usual parameters. We'll talk about them later. The treatment abroad scheme, this is our data from this year, and this is a problem in that multiple centres are involved. Maybe it should be 1, I'll talk about that in a second, but as it stands, 2 patients who Chris Dorr and I share have been to Uppsala this year, 3 to Rotterdam, to the Erasmus Hospital, 1 to the University Hospital in London, and then 1 is just about to go to King's Hospital in London. So why so many? There's many reasons, and we may go into that with the Q&A later. What's the best institution? We'll go into that with the Q&A later. They're all world-class centres. I trained in North America. Not a single NET patient in North America, when I was there, had access in their country to lutetium or any type of metabolic treatment, which is quite amazing. Anytime in clinics, and I worked with some of the world leaders in cancer, I was privileged to do that, anytime we saw a patient whose disease was growing on octreotide or chemotherapy, we always used to say this, and that was flight to Rotterdam or Uppsala, because there was no treatment in North America. So we're quite privileged that we have access to all these institutions that are close to home. So a lot of successes. I mean, clearly Mark's organisation and many of the wonderful people here who set up this NET patient network, this is an incredible thing to have done, and it really has brought it forward in my view. National centre and satellites, this is critical with rare diseases. There should be 1 big centre and satellites that feed into this who treat patients locally, and I totally dial into that, and Chris has alluded to that also. We're lucky to have a true national expert in Professor Dermot O'Toole, who I talk with all the time about the logistics of treatment, about complex cases, etc. I know Chris Dorr does as well. More treatments. We've more treatments now, which is wonderful. Not just lutetium, but we've chemotherapies, we've longer acting octreotide therapies, many other treatments that I'm not going to go into here because this is not an academic talk. And also the treatment abroad scheme. Other countries in Europe don't fund patients to get treatment abroad. Many of my patients have met patients from South Africa, from Belgium, and if they're in Rotterdam or Uppsala, amazingly, their governments don't really pay for the treatments, whereas we're privileged that our government does, and I've rarely had a problem with the treatment abroad scheme, and I'd like to congratulate them on everything that they do, because my experience personally has been fantastic. I hope yours has. But what about problems? I mean, that's the purpose of this meeting, about addressing problems. There is no database. There's been a lot of work done, but nothing rolled out, so we don't really know, benchmarked against the best of the rest, how we're doing. IT is a problem. In the world we live in, it's all about information technology. So we should have more apps on iPads. We should have more MDTs that are done virtually through James's, with Galway involved, with the HSE, South-Southwest involved, etc. And there's work being done on this, but it's slow, it's stubbornly slow. There should be 1 centre for referral overseas, in my view, and maybe Tommy can talk about that later. Metabolic imaging, gallium scans, etc. We should have the facility for this in Ireland. Why don't we? If a patient needs a gallium scan, they have to go overseas, and this, surely we should have this at home, and I know there's work being done about this. Biochemistries, the whole chromogranin, the 5-HIAA, where do we send these? How long does it take? Who's governing the contracts? This is all very vague to me. There needs to be one centre that we send them to. And very importantly, and this is often ignored, NETs includes other diseases apart from carcinoids. It includes paraganglioma, it includes pheochromocytoma, other rare hormone-secreting tumours. We shouldn't forget this, because there's many patients, some are here, who have these diseases who've gone overseas. So thanks for your attention.